Okay, now, so we move on to the second session, which is dydrogesterone, the role of dydrogesterone in endometriosis, a specific role. And for this, I invite the chairpersons. Meenakshi, are you sharing the slides? Introductory slides?
Yes,
Dr.
I am sharing.
Rohit is sharing.
Okay, Rohit, will you share?
Yes.
The next slide, Dr. Meenakshi Sharma. She's a secretary of East Delhi Gynae Forum, and she's a very highly academic person. So all of us really love her. Next, Dr. Jyoti Malik. Next, Dr. Jyoti Malik. She's a senior consultant Obs and Gynae ART specialist and secretary at DGF Outer Delhi. Next, Dr. Seema Sehgal. Another luminary, she's expert in operative hysteroscopy and laparoscopy, and she's medical superintendent and HOD at MKW Hospital, Rajouri Garden, and director of Obs and Gynae, CK Birla Hospital. And she's doing laparoscopies and hysteroscopies a lot. Then Dr. Rupam Arora, ex-president of East Delhi Gynae Forum. She's at present working in Cloud9 Hospital, Patparganj. Next. So Dr. Jyoti Agarwal would be speaking on it, and we know she's a senior consultant and director of Life Care Center and Life Care IVF, and she has been the past president of DGF, and she will be talking about dydrogesterone in endometriosis. I invite you, Dr. Jyoti, to kindly share your screen. Rohit, you can stop sharing the screen.
Yes,
thank you, Doctor. I will just start sharing my screen. Rohit ji,
Right.
मैं share को क्लिक कर दिया. अब यहाँ पे मेरे पास 4 चीजें हैं. Click the screen 1. There are 4 things coming on my thing. Screen 1.
मैम आप जो आपका पीपीटी है ना, वो जिस विंडो में खुला हुआ है उस विंडो में, अगर आपके गूगल साइट पे खुला हुआ है या पीपीटी पे पावर पॉइंट पे खुला हुआ है, वो वाला आप उसको क्लिक करो.
उसको क्लिक करना है. Okay. I have clicked it now.
click it, double click it.
और जस्ट
शेयर कर दूं अब. शेयर को क्लिक
हाँ जी, ये शेयर का उसमें ऑप्शन आएगा, शेयर कर दीजिए. मैम
Are you able to see my slides now?
यस मैम,
Yeah, there.
यस मैम, डन मैम, यस. इसको मैम फुल स्क्रीन कर दीजिए.
Make it full screen.
Full screen, yes.
यस, डन. यस मैम, गुड टू गो.
Not full screen as yet.
So thank you very much, the organizing team, Dr. Vandana, respected seniors and my dear friends. It's my pleasure and privilege to talk about the new avatar, that is dydrogesterone in the treatment of endometriosis. So let's give it a new look and let's see what all is there in favor of it. We just heard that chronic inflammation is the core of endometriosis as far as its pathogenesis is concerned. And what does this chronic inflammation do? It causes progesterone resistance in the endometrium. Hence, progesterone action is very crucial to decrease the inflammation of the endometrium. And this molecule, that is dydrogesterone, effectively tackles chronic inflammation by 2 ways. The first is by increasing progesterone receptor expression, and the second by decreasing the pro-inflammatory cytokines. And this, let me just drag this thing because it is coming in between.
क्या चीज में?
Dr. Jyoti should be louder.
Louder. Yeah, I will just move closer to the screen, I suppose. Is it better now?
Yes.
Yes ma'am, voice is good.
Yes.
Are you able to see your slides, ma'am?
Yes, I'm able to see the slides.
Yeah,
Yes.
good.
Yes, so I was talking about the pro-inflammatory and the anti-inflammatory cytokines. This molecule reduces to TNF, that is, and the nuclear factor K activation, and suppresses so many other interleukins like 8 and increases the NO production. And all this plays a role, has an anti-inflammatory role. So what are we aiming for? We are aiming that endometriosis therapy should enhance the quality of life and reproductive health. Dydrogesterone enhances both quality of life and reproductive health because it leads to reduction in the pain symptoms. It reduces the size of the endometriomas and hence improves the quality of life in all spheres of life. As far as infertility is concerned, there is no inhibition of ovulation. It is widely used left and right in the luteal phase, and thus overall it improves the pregnancy outcome. Now let's see what all clinical evidence we have in favor of dydrogesterone in the management of endometriosis. First of all, let's see how do we relieve a symptomatic patient, that is mainly the pain, and improve the quality of life, and the second part will be the infertility part. Dydrogesterone was first reported to be effective in endometriosis as early as 1960, that is almost 60 years back. And most of the studies in literature show that overall success rate is around 90% with cyclical use of dydrogesterone from day 5 to 25 day of the cycle for 4 months. And this has been confirmed with laparoscopic examination as well as ultrasound findings. In fact, laparoscopic examination after giving dydrogesterone confirmed that there is elimination of endometriosis in almost 75% of the cases, and another 15% of the cases showed improvement. And the same thing on laparoscopy, it was seen that dydrogesterone inhibits the development of new endometriotic lesions also. And this latest study from 2021 in Japan, this proves that it causes atrophy of the ectopic endometrial tissue also. So combining all the laparoscopic findings, the authors concluded that dydrogesterone inhibits formation of de novo endometriotic tissue while leaving the endometrium unaffected, and hence the pregnancy outcomes are good. We all know that recurrence rate of endometriosis is very high after laparoscopic surgery, and we don't have to do a repeated surgery. So post-laparoscopic treatment of endometriosis with this molecule, it's very effective, and this is an Indian study by Trivedi et al., which is an open prospective multi-center study. 98 patients were included with mild, moderate and severe endometriosis with or without infertility who had undergone laparoscopy, and then they were treated post-operatively with dydrogesterone. After first cycle of treatment, the success rate was somewhere in the tune of 30 to 40%, but after 6 months, it was seen that pelvic pain, dysmenorrhea, dyspareunia, everything reduced almost to the tune of 90 to 95%. And if we see the breakage, they concluded that 67% of the patients showed improvement and 20% of the patients were cured with this molecule. Not only this, there is a high satisfaction with this therapy in patients of endometriosis, both by patient and doctor, and almost 75% of patients and doctor rated it as an excellent. So dydrogesterone is an effective and safe post-laparoscopic treatment of endometriosis to prevent recurrence. Now coming to infertility. We all know that management of infertility in women with endometriosis is a complex issue. So we need a drug which will not cause an ovulation, and it will improve the pregnancy outcome also. We all know that current medical therapies, both hormonal or non-hormonal, have been fairly successful so far to provide symptomatic relief, but they all inhibit ovulation and they delay conception. So there is a requirement of a therapy that can avoid unwanted side effects, specifically target the lesions without affecting the ovarian function. Dydrogesterone does not inhibit ovulation unlike other estrogens. It does not affect serum estradiol levels, and since dydrogesterone therapy does not cause hypoestrogenic state, estrogen add-back therapy is not needed. At the same time, it induces decidual transformation and causes necrosis and resorption of endometrial implants, and thus improves pregnancy outcome. It also causes upregulation of progesterone-induced blocking factor, as has been discussed much about it, and blocks the pro-inflammatory cytokines, and all this improves the pregnancy outcome. And not only this, the metabolite of dydrogesterone, which is dydrogesterone, it retains immunomodulatory effect as its parent compound and improves the uterine flow, the subendometrial blood flow. It increases the uteroplacental circulation and thus improves the endometrial receptivity and the pregnancy outcome. So the authors concluded that dydrogesterone has a favorable safety profile for women who wants to conceive, as it is highly selective for progesterone receptors. It minimizes activation of other receptors, so we don't have other unwanted effects like mineralocorticoid or other effects. There are no estrogen-associated side effects, and so far no intrauterine death, congenital abnormalities, or pregnancy-related complications were noted. And overall, it improves the quality of life. Efficacy of dydrogesterone in women with endometriosis after reconstructive surgery was compared with five other drugs also. This is a study where 300 infertile patients were taken up and they were divided into 5 groups. To one group, Depo-MPA was given. To the another group, dydrogesterone, then norethestron, denazole. And there was one group where no medical treatment was given and only coagulation was done during the laparoscopy. And it was found that 50% of the patients, they were asked to follow up after 12 months. And it was observed that 50% of the patients become pregnant with dydrogesterone, whereas a slight, very minimal increase, 63% with denazole. But the important thing to remember is dydrogesterone does not inhibit ovulation and can be used before and during pregnancy, whereas denazole induces a state of pseudomenopause. All of us know about it, and it delays conception by at least 6 months, and anyway we are not using it. So the conclusion is dydrogesterone is the most effective therapy and the most preferred drug for endometriosis. Now let me share some latest updates on use of dydrogesterone in the treatment of endometriosis, and these updates are as latest as 2021. This is a large multi-center clinical trial, goes by the name of Orchidia, and it was done to see the efficacy of dydrogesterone in laparoscopically confirmed cases of endometriosis. A total of 350 patients were taken into account, and they were given 10 milligrams of dydrogesterone 2 to 3 times a day, depending upon the severity. The important thing here is to remember they were divided into 2 groups. Either they were given cyclically, I will be talking about it in my subsequent slides, or they were given continuous treatment with dydrogesterone and they were followed after 3 months and 6 months. And it was noted that there was a significant reduction, almost to the tune of 52%, as far as chronic pelvic pain was concerned. But important thing to remember is the difference between the two treatment regimes, that is whether you give cyclical or you give continuous, was not statistically significant. So the authors concluded that dydrogesterone leads to a similar and a significant improvement in chronic pelvic pain with either regimes. So we can go whatever is comfortable or convenient to the patient. And the same study also showed that the overall reduction in use of analgesics was statistically significant, almost to the tune of 8%. So not only the chronic pelvic pain, other pains like dysmenorrhea, dyspareunia was also reduced almost to the tune of 50%, and hence there was an improvement in the sexual well-being of the patient. So treatment with dydrogesterone led to significant improvement in multiple measures of quality of life, be it perceived health, mental health, pain, physical functioning, role functioning, social functioning in this study. So it proves to be a good drug. And not only this, that it improves multiple spheres of the life, dydrogesterone improves quality of life during all the 4 stages of endometriosis, be it mild, moderate, severe, or 1, 2, 3, and 4 grade of endometriosis. And the dosage recommended is 20 to 30 milligrams per day for 6 months or longer. And we can either use it continuously or in a cyclical fashion, that is, you start from day 5 and give it till day 25. So this is the dydrogesterone is the gestation of choice. To wrap up both the talks, I would like to give the key messages. Endometriosis affects 10% of women during their reproductive age, of which up to 50% suffer from infertility. Delayed diagnosis is a major problem, leading to increased distress among the patients. Infertile women are 6 to 8 times more likely to have endometriosis than fertile women. Medical treatment should regress endometrioid lesions, pain, while preserving ovarian reserve and fertility during long-term use. It should effectively relieve endometriosis-associated pain with minimal adverse effects. It demonstrates anti-angiogenic and anti-inflammatory effects. It blocks proliferation and facilitates apoptosis of endometriotic lesions, does not suppress ovarian function when given at therapeutic doses, and preserves fecundity. There is no delay in conception, only compensates for luteal phase insufficiency. Hence, dydrogesterone is an effective choice for management of endometriosis associated infertility. Thank you all for being with me to have a new look at this molecule.
So all questions related to endometriosis, related infertility should be asked. We are not going to dwell on adenomyosis. We are not going to dwell on the at this particular time on the adolescent endometriosis. Questions related to endometriosis related infertility. Treatment.
Shall I stop sharing? Stop sharing.
Please, madam, stop share kar dijiye.
Yes.
Dr. Vandana, you need to unmute yourself. Dr. Vandana, unmute.
Yeah, there is a question from Dr. Kalpana. Thanks, Dr. Jyoti, for such a wonderful presentation. So I'm taking the questions first, and then, or should I take the expert comments first?
Take the expert comment first.
So, Meenakshi, you come in. Meenakshi seems to be busy. So, Dr. Seema Sehgal. Dr. Seema Sehgal.
Yeah, excellent talk, ma'am. Jyoti ma'am, it was so good that it's a like eye opener for me. And because dydrogesterone we were using for luteal phase support definitely, but for endometriosis this is the proper elaborate treatment you have discussed. So nice of you. I think dydrogesterone, because of the multiple players are there nowadays, so it is more in use because of the multiple brands are there. Secondly, the comfort and the ease which we can use, and with less of the side effect. Advantages you have absolutely elaborated. And previously also I was empirically using in dysmenorrhea, but definitely for endometriosis this will be a good thing to use. I don't know what to add on. It was absolute good talk. Thank you very much.
Thank you, Dr. Seema. Thank you, Dr. Jyoti Malik.
Already using it for endometriosis, I would request them to please share their experience.
Dr. Jyoti Malik.
Yeah, thank you so much, ma'am, and thank you, Dr. T, for that wonderful talk. Though we are not using it that very frequently for infertility, but since after listening to your talk, I'm sure that we are going to use it more often now. Because as such, it is not only improving the quality of life, number one, that we want, because dysmenorrhea and pain that it is causing is in itself leading on to infertility. So on one hand, when it reduces that, maybe certain factors of infertility can be taken care of. And the second thing is because it does not hamper the ovulation. And in fact, it is more of anti-inflammatory and more acting on the endometrium. So on not only improving the oocyte quality, also improving the endometrial receptivity. So it is a good drug of choice actually in cases who are infertile and also symptomatic. So in those particular cases, it stands a very good chance. Thank you.
Dr. Jyoti, both of you can answer. There's a thought which crosses that we are giving this duphaston, which is a progesterone, in the follicular phase. Would it affect the endometrium at that time? Or would it counter the effect of estrogen on endometrium at that time?
See, the question is, what is it doing? There are two regimes, she has told. Either you can use the continuous way, or you start on the 5th day and stop on the 24th day. Right. As far as symptomatic relief is concerned, as far as quality of life is concerned, everything is great. Now, what it does, this evaluation has been there in the form of case reports, small studies, except the ORCID study, which has been done in Japan, where the numbers are significant. So I think, people never thought of, specifically using it for endometriosis. We were talking about use of in-threatened abortion. We were talking of its use in recurrent miscarriage. We were talking about its use in luteal phase support in ART cycles. But, this all had been a retrospective kind of a thing. You could see Dr. Prakash Trivedi's study, which came in 2007, 2008. It was a multicentric trial, and they found it was a great relief. Somebody asked a question, how long the therapy therapy has to be given. Those people had used it initially for 6 months, and you find if the patient is symptomatically better, she herself will continue. Am I clear? She herself will continue. And what this particular study by Dr. Jyoti Agarwal brings out, that probably it will help in pregnancy also. It will help in pregnancy. And we have to see it from that particular point of view, light. As far as the cost of the drug is concerned. See, we have been using this particular drug for a very, very long time. We know that it does not have any give rise to any GI symptoms or anything of that particular kind. And very beautifully is highlighted as far as the pregnancy use is concerned. There has been no extra malformations and things like that. It is pretty safe. So the question is, if the cost can be maintained, it is all depends upon is now the cards have been opened that there is another indication for its use, that is endometriosis related infertility.
Ma'am, one more thing that I was under the impression was that it has to be a continuous therapy, but now that in this study it was shown that whether it can be with that 5 to 25 day cycle or we use it as a continuous, the results are same. So it can be used either way, that way. Initially, we were thinking that let's give it without a break for continuous 3 months so that there is no withdrawal bleeding, and that is why there is a pain relief and the endometrioma size does not increase and all. But these studies, they say that it can be used with that cyclically as well. So that is one more thing.
Now, for it to class as a grade 1 evidence, I will not say, because there are no randomized control trial. But what I feel is, now in future, probably people are going to work on it. But whatever the drugs are available, they inhibit ovulation except this particular drug.
Right.
Dr. Jyoti, any studies?
इसको सोचने की जरूरत है. There is a lot of food for thought that there is another indication as far as this particular salt is concerned. Now, as for the different salt is flooded in market, everybody which comes to your clinic wants to do a CME on dydrogesterone. Doctor virtual meeting kara do, doctor physical meeting kara do, but ye kara do, wo kara do. It's all dydrogesterone. It is for you to make up your mind. Here I wish to tell you, this particular salt has been there in the market for 60 years. But the other people we have joined, they are not there for 60 years. People have come and gone that has seen what it is. There are people now who have started big plants only for dydrogesterone. It's a big market. It's 1,000 crore market. So we are not going to dwell on it, which salt to be used, which company you should patronize. We have just now told you that I just reviewed endometriosis in the light of chronic inflammation, what all are other things which are bringing chronic inflammation. So I think each gynecologist should be very clear about this thing. Till now we have been using it, immunomodulating effect in recurrent miscarriage, but I find it has got the same effect as for the infertility related to endometriosis is concerned. Everything is the same.
Okay, thank you, ma'am. I would ask the audience if Dr. Rupam is there.
Ma'am, I just want to say that we are using it in cyclical dydrogesterone from day 5 to 25. In the initial follicular phase, it will not adversely affect the endometrium. If we use it only in the luteal phase in the people who are desirous of conception, and if it has the same efficacy of preventing an endometriosis, I think it is going to be better.
So these are the patients who
they have used dydrogesterone in a low dose, 10 milligrams from day 5 to day 15, and then from 16 to 25, they have increased it to 20 or 30, depending upon the requirement. But they have not stopped even in the follicular phase. They have used it as a low dose.
Okay. And it has not adversely affected the conception
outcome.
Dr. Jyoti Malik is here. There is a big proposition that the progesterone can be, it is it can be used as an anti also. So I think a lot of work is going to come in this particular area. That are much cheaper drugs to anti as far as this. We do not out in a very similar way. And he has brought about very small studies. Only the ORCID study has been there, which is from Japan, which is a long study. It's still not very large.
That is the latest one, but only 350 patients. उससे बड़ी और studies अभी है नहीं. Maybe now future is open to that.
And Dr. Jyoti, the study that you showed, it compared with 5 other drugs. In that Dydrogest, there was no comparison with Dydrogest.
There was no
Yesterday, my madam was discussing about this. There is no study which has compared these two.
But vis-a-vis Dydrogest, if we are giving it in the follicular phase as well, continuous as well, it's safe in pregnancy in case the patient conceives. So we are assured that there would be no adverse events. Right?
But Dydrogest also does not.
Even if the patient conceives on Dydrogest, we say you don't have to discontinue the pregnancy, but still we are a little bit apprehensive. Over here, we will be very secure. Right.
Yes, and on top of it, it has a role in the luteal phase also.
Obviously, it is a progestogenic agent. It will have a role in luteal phase. So there is a question by Dr. Kalpana. That a 29-year-old patient with bilateral endometriomas, probably 7 to 8 centimeters, with increase in ovarian volume. How would you treat?
Doctor, let me be very frank, is that, the clinician has to make up a decision about her. If you find that they're large bilateral endometriomas, you have no other choice. You have no other choice but to go for surgical treatment. And thereafter, once the surgical treatment is there, you don't have to stop the drug. You can use dydrogesterone. It is going to prevent the recurrence as is concerned. It is going to prevent the return of pain because of the chronic inflammation, because of the residual disease. So all that kind of things in a post-operative period, normally till now we've been saying no hormonal treatment, but dydrogesterone can be used in those cases. So it will not prevent pregnancy as well.
Ma'am, one more thing, some studies have said that doses as low as 2 mg is also as effective. So I would like opinion of the house that because it has been mentioned in Dr. Jyoti's talk 10 to 20 mg per day. Few articles I went through, they have used even as low as 2 mg and they said the results were as good. So I don't exactly know how many, because just what should be the dose ideally?
And these are these are just small case reports or small studies. So we cannot go by this. 2 milligrams is anyway not available also. The dose minimum is 10 milligrams, but they say 20 milligrams for mild cases and 30 milligrams for severe cases. So 10 milligrams either 2 times or 3 times a day. And if you are too scared that the follicular phase will be affected, you can do 10 milligrams in the first 5 to 15 days, and from 16 to 25, you can increase it to 20 milligrams. If the patient understands well.
Somebody has asked question of the breakthrough bleeding. Breakthrough bleeding has to be managed in the same way as you've been doing otherwise.
So there is a girl of 10 years of age, she comes with dysmenorrhea.
No, doctor, we are not talking those questions with dydrogesterone. Everybody knows what are the alternative drugs are available. Dydrogesterone is only for endometriosis related infertility.
How long to use a dydrogesterone to continue using it?
6 months, but if the patient is improving, then you may continue for a few months more. There is no harm. But the upper limit they have not yet reported in the study. They have said 6 months or longer depending upon the symptomatic relief of the patient.
Okay. In infertile patients during time, or should it continue alongside with Ledros?
It depends whether you have already stopped earlier. If the patient has already taken for 6 months and now you are going for ovulation induction, there is no point restarting. You can just give the luteal support. And if she's already continuing, you see whether the patient has symptomatically improved, then only start ovulation induction.
So you mean to say that you give ovulation induction, no dydrogesterone at that time, and in that cycle, you give dydrogesterone in the luteal phase, not in the follicular phase. Right? So that completes the answer. So breakthrough bleeding, madam has already taken. So because gestogenic agent, breakthrough bleeding would be part and parcel.
No, so there is so much to play with
manage
this,
it as usual.
The dose can vary from 20 to 30 milligrams. And the breakthrough bleeding will always come in the luteal phase. So I think, you can play around at that particular time.
You can increase the dose, yeah. So,
the basic idea of this particular presentation is to open up your minds. There is another indication for as far as this salt is concerned. That was the very idea about it. I'm sure in the future, many more studies will come, many more randomized trials are concerned, and the backup of Abbott is there. So I'm sure it will be international trials, in a proper way, as they have done it for the luteal phase support.
Very well said, ma'am. And one more thing that with the dydrogesterone, once post surgery, we are giving dydrogesterone for 6 months, and then after that we are starting with the ovulation induction. And then in the luteal phase, if we give dydrogesterone, it is going to suppress the disease further for a longer time.
Perfect.
So we can continue giving ovulation induction and just give a luteal phase support with dydrogesterone.
The basic idea of this presentation is that you should know new avatar has come. That's all. Nothing more than that. It is the beginning. I think, the more studies are going to come. I'm going to ask Dr. Jyoti Malik, any comment? Last minute, Dr. Sehgal, you want to make, or anybody wants to make any comment? Dr. Seema Sehgal, you want to make any comment?
No, ma'am.
Jyoti Bhaskar, you want to make any comment?
It's clear.
As you rightly said, it's a new insight. It's just making us all aware that.
Insight.
Yes, and a new
The
thought.
only thing which the basic part which I wanted to highlight is that, you must know the days are gone. Now you should talk in 2020 how chronic inflammation is the core behind all the problems in endometriosis. And all of you should exactly know about it. First, the blood will come on the peritoneal surface. Then it is going to make its way. The increased blood supply is going to come there. It is going to make implant, macrophages production will come, and all bad things are going to come there. They will come in the implant as well as in the peritoneal fluid. And when it is all studied with pro-inflammatory cytokinins and growth factor and other things, then you find patient becomes miserable because of all this. And because the progesterone resistance is there, progesterone is not working. So जो झाड़ू लगाता है प्रोजेस्टेरोन, जैसे बोलते हैं ना मेडिकल क्यूरेटाज करता है उसमें एंडोमेट्रियम में, उस तरह बाहर भी मेडिकल क्यूरेटाज करता है, but that झाड़ू is not allowed to act because of the progesterone resistance. Otherwise, every time the retrograde menstruation comes, retrograde menstruation happens in everybody, but the people who are pro genetics wise और जो भी कुछ उनका प्रो फैक्टर होगा, अगर वही होगा तो उसके अंदर आपका endometriosis होगा. In comparison to the other people also who do not develop endometriosis, they overcome that kind of a thing. So it does not explain why 100% endometriosis is not there. There's some mechanism must be working there. It is just giving an insight to you. This presentation has been only brought with an idea that another indication for you. Think about it. So I think, thank you very much. Yes, Dr. Jyoti Malik. Doctor, unmute yourself. आपकी आवाज नहीं आ रही.
Unmute yourself, Dr. Jyoti.
Yeah. Ma'am, जो progesterone झाड़ू बोला है, I think we'll remember that. This particular dialogue we'll remember. और फिर याद रखेंगे कि progesterone resistance को ये कम कर रहा है. तो ये बहुत आपने you've given us a very
apt description. Apt description, yeah. For scar endometriosis, there's another question.
I think this gives an insight. And Dr. Jyoti Malik, you are reminded again that the meeting is there on the 21st as far as Infertility and IVF Committee is concerned. And you are speaking on the role of OCP in ART, and Sir is speaking on hypo-responders. It is going to be great meeting on that particular day. People who are not even practicing IVF can definitely go. How to get synchronized follicles. Till now we have been giving OCP. Dr. Malik is going to talk about the OCP, and he's going to talk alternatives to OCP on that particular day. So he will probably open up many things. And as an infertility student, I will say the time has come to open up reproductive endocrinology books. So know something more about estrogen, progesterone, other things as well. So thank you very much. Dr. Jyoti Agarwal, you want to say something last minute?
Thank you very much for giving me this opportunity. I was just thinking about that breakthrough bleeding. since it does not cause any hypoestrogenism, there is no effect on the estrogen, so breakthrough bleeding hona nahi chahiye, theoretically speaking.
Correct. Only you have to modulate the doses.
Yes.
Okay. Thank you, everybody.
Thank you, everybody.
So we conclude
Somebody asked
today's
me, Dr. Manju Parik asked me about the asked question on adenomyosis. Adenomyosis is a bad disease. It does, but medical treatment doesn't work on adenomyosis.
Right.
So I think with this, great going. Thank you very much for attending in large number. So thanks very much.
Thank you.
Thank you, everybody.
Thank you very much, ma'am.
Dr. Abbott के कुछ लोगों को कुछ बोलना है, Madam Rohini, you want to say something?
Ma'am, actually, Dr. Rohini is not available today. Myself, Rohit Tripathi. So I would like to thank all of you for a great discussion and meeting this, making successful this. Thank you.
Thank you, sir. Thank you very much.
Thank you. Thank you. Thank you, everybody.
Thank you so much.